Welcome, my V Health Empowered family. Thank you so much for coming back for another episode of Excuse Me, Doctor. My name is Dr. Melissa Clark, and of course, I love when you call me Dr. Mel. We're here doing what we do every week at Excuse Me, Doctor, which is making sure that you have all the information, the evidence-based, science-based information that you need to make wise health decisions, not just for yourself, but for your family as well as for your community. So thanks for tuning in, whatever platform you're catching us on. If you're a newbie, welcome to the family. And please hit that subscribe button if you're watching on YouTube, and hit that like button if you're watching on Facebook. Really, really, really appreciate you for that. And of course, like I said, we're here so that you can make wise health decisions. And a lot of times that means you'll have questions. So please go ahead and type those questions into the chat, because we are here for you. We're here for it all. And of course, to make it happen, I need by my side Mr. Wayne Bruce, my incredible producer and co-host. Join us on camera. Wayne, how you doing?
How are you, Dr. Mel? How are you?
I'm doing great. I'm doing great. Can't complain. We're about to get into this amazing week with all this great health information we're going to cover. So I'm all good.
Dr. Mel, I have to first start by saying, I'm the producer by trade. So I'm going to have to ask you to pull the mic a little bit closer, because we want, as they say in Northwest Washington, D.C., that good sound.
Okay. All right. So is it a good sound now?
It's good sound now, Dr. Mel. It's good sound.
Wonderful.
There we are. I'm excited, Dr. Mel. I'm excited.
Why? What's on your mind?
I've been a business owner and an entrepreneur for a long time. And
Okay.
I wish somebody would have had a show like this to explain to me just everything dealing with insurance.
Well, we're here for it tonight. We talked about Medicare and Medicaid a couple shows ago. Now, tonight, we are going to focus, just like you said, on what everyone needs to know if they're choosing health insurance based upon their employer, or if they're self-employed and they're buying it out on the open market. What do you need to know to get that good, as they say, that good insurance, right?
That good insurance. I want the good insurance.
Exactly.
Nobody wants the bad insurance.
Right. And we're doing this live during open enrollment season. So there are a bunch of choices, lots of choices, little time. So we're going to be going over how to choose that right plan for you.
Yep.
So definitely share it.
Share. Right. Yeah. Don't forget to write your questions. Any questions you may have. So on whatever platform you're on, in the chat, and I'll see it.
Exactly. And the people you can share it with, everybody, but especially people who don't have insurance right now, who are underinsured, business owners, small business owners, people that work for companies and need to make that, choice of a health plan at their company. Share it with all those people. They need to hear this.
Everybody. All right. But before we do, we have to go into the week that was.
Yes, our weekly
health
recap.
And wellness, right? Here we go. The recap. Dr. Mel, running from your life. Yeah. Run for your life.
I'm running from your life.
but it's run for your life. Are you being
Yes.
chased by a bear or what? What's the deal?
No,
What's
no,
run
no,
for your
no.
life?
This is all about exercise and running as an exercise. It turns out that people who are runners tend to live longer and have a lower risk of heart disease and cancer than non runners. That's
So
what
I
it's about.
need to run to get all those benefits. Most people don't have the time to do marathon training. I don't have that time, Dr.
Right.
Mill.
So it turns out that there's strong evidence that even very short, occasional runs boost longevity and mental well being. One study showed that compared to non runners, people who just ran 1 to 2 hours a week for the whole week at a slow or moderate pace had better health benefits than people that ran a lot, right? And then another study showed just 5 to 10 minutes of running at a slow pace a day, those people showed the same improvements in health as people that ran much more than that. So the bottom line is you don't have to do a whole lot
You don't
to
have to
get
do
the
a whole lot.
benefit.
You don't have to. So why is it so good for you? I mean,
So it releases exerkines. One of them is scalaxin into your bloodstream.
hold up, hold up, hold up.
Uh-huh.
Scalaxin, what's that?
So those scalaxin is an exerkine, and exerkines are chemicals that your organs release in response to exercise. And these chemicals, these compounds, actually reduce harmful chronic inflammation in your body. They generate new blood vessels. They help your cells produce energy, so you feel better and you do better. You're more healthy overall.
Wow. So I don't have to be on the track team, former track star.
No, you
I
don't have to
can
be from Kenya and win the marathon and the Olympics. You don't have to do all of that.
hey, some to
You
those
can
Kenya runners. It's
right, yeah.
something. They
Just
have
5 to 10 minutes a day or 1 to 2 hours a week.
cool. All right. Number two, falling back could be a step forward in your health. So look, most people listening to the show fell back into standard time. We know what that is. Standard time is in the fall, November and spring, November through March, which is based on the position of the earth relative to the sun. You didn't know I knew that, but I'm telling you, I know it. Daylight
Wayne Bruce
saving
wisdom.
time, daylight savings time is the period between spring and fall. You didn't even know I knew that, but I did because I just had to fall back. Where the clocks go forward 1 hour, resulting in a loss of an hour of sleep, more darkness in the morning and more light in the evening. So tell me your opinion. What's better
Mhm.
for our health?
So not just my opinion, actually studies are showing that standard time is better for our health because it matches our body's internal clock. So when we get more light in the morning and more darkness in the evening, our bodies are more aligned with nature. And so it makes it easier to wake up, easier to fall asleep. Whereas when we go into daylight savings time in the spring, that disrupts our internal clock and it causes less sleep, poor sleep, and in turn, that leads to negative health consequences. So, when we turn the clock, back and forth, when we alternate, it has health repercussions. We see people have more heart attacks, more strokes, more mood disturbances, even suicides go up.
So why aren't we just sticking with standard time?
From your lips to God's ears, we need to just stick with one thing. And there are tons of groups like the American Society for Sleep Medicine, which is lobbying to just stick with standard time year round. So if you really feel so motivated, you can write your congressman and tell Congress stick with standard time because it's better for our health.
Wow. And you heard it right here on the Dr. Mel Show. Write your congressman, please. So,
Yeah.
look, number three, recap number three, intermittent fasting. I can't say that fast. I can't even say fasting faster than I did. Look, intermittent fasting for the win. Look, so you got all these diets out here, and outside of Ozempic, the next one I hear about a lot about is intermittent fasting. What's the deal?
Okay. So intermittent fasting, which is also called time restricted eating, which is probably a better description. It
I
means
love
you're
that.
taking all your right, you're taking all your calories in a shorter period of time. Generally 8 hours, but I've also seen 10 hours, up 10 hours or 12 hours, but you're taking your calories in a specific time period. So a new study showed that people who do intermittent fasting without even having to count calories, right? They had more weight loss if they were type 2 diabetics or obese compared with people who just restricted their calories but ate at any time of the day.
Wow. So no calorie counting. That's the way to go. It makes it easier to stick to, I bet you.
Yeah. Well, that's exactly the case. So the people in the intermittent fasting group, you're right, it is hard to say fast. Um,
Telling
they
you.
actually they ate fewer calories. They were more able to stick to the program compared to the people who were just trying to restrict their calories. So, you know, paradoxically, the people that weren't really trying to restrict their calories got less calories. And it turns out that it was great, both methods, the calorie restriction and the intermittent fasting, for people
Hmm.
with diabetes, it decreased their A1C, so they worked
Hmm.
kind of equally. And if you're going to do this or start intermittent fasting and you're diabetic, it's really though important to do it under the supervision of your doctor because it's probably going to cause you to have to, change your medication regimen a little bit, probably a little bit less. So you
Hmm.
want to do it under the supervision and guidance of your doctor.
I'm excited. I'm excited for all my people to get off of different medications. And if this is the way eating, between the hours of what 12 and 8 or 11 and 7 and or
Hmm.
however they want to do it, I'm excited for
Yep.
you because I'm in that bunch. So I don't take anything for granted. You hear me?
Yeah.
Nothing. Not
Yeah.
one thing. So
Yep.
look,
Well, it works.
so Dr. Mel, we got to reach back into the Wayback Machine. We got to go way
Okay.
back
All
because
right. How far back we going? Uh
we're
huh.
bringing back the what? The weekly debunk. Stopping misinformation in its tracks. We're bringing back the weekly debunk. So I got a
Wow, I'm
text.
excited.
I got a text. The Twitter finger family is no longer texting me. It's now the
Wow.
boy family.
What?
Yeah,
Okay.
it's the big
The
boy family.
boys.
It's
Okay.
the big boys. We call
The
them
boys are on the
the
block.
boys, but they have a daughter, so it could be the girl too, but it's really the boys. So
Okay.
the big boy hit me and said, "So I told y'all if I get the big C, I'm team all natural. Ginger is up to 10,000 times more effective than chemo in treating cancer. Holla at your boy." Literally,
Okay.
the boy.
The boy family. Okay,
Right.
got it.
So I texted back, I said, I don't know about that. Excuse me, Dr. Mel, is that true?
Well, no, in a word. But I think I know that he got that because that was a post, I think, that was on social media that got shared about 800,000 times, literally. Um, so there are some studies that show that ginger is good for you. And that in a petri dish, right, ginger is effective against cancer stem cells, so cells that give rise to cancer. And then there was another study at Georgia State University that stated that whole ginger extract exerts significant growth inhibitory and cell death effects on some prostate cancer cells. So that means that they can help kill prostate cancer cells. But get this, these were only done in a petri dish, in a lab, in cell cultures. It was not tested in actual humans. So there's no like head to head comparison of chemotherapy versus ginger in humans. This has not been done. So there is nowhere in any peer reviewed, published journal or any uh, published study that actually can back up that claim. So the bottom line is ginger does have some medicinal effects. We know it's great as an anti-nausea uh, uh, anti-nausea compound to take. And it is used in chemotherapy for people who are experiencing nausea and vomiting as a side effect. But the claim that it kills cancer cells better than chemotherapy, there is absolutely nothing to support that. So please tell Mr. Boy that that is not the case.
So I'm gonna have to holler at my boy. You get it. I know you get
Yes,
it, Dr.
I,
Mel.
I,
I'm
I
gonna
do.
holler at my boy and tell him he's dead wrong.
Okay. Well, thank you. And thank you for bringing that to the surface. We appreciate you. We're going to
What I
catch you
do.
back in a minute because we are about to go into this health insurance segment that I know people are waiting to hear about. So, we all know that medical costs are out of control often, and 40% of Americans have some form of healthcare debt. But according to the Kaiser Family Foundation, the people who are most likely to be affected by medical debt are women, Black and Hispanic adults, parents, and those with lower incomes. And not having enough health insurance or the right kind of health insurance or being underinsured is part of the contributor to that medical debt. But how much insurance is enough insurance? How do you know you're buying the right plan for yourself or for your family so that you don't get caught out there? So, we're covering it here today with an incredible guest, Mr. Mike Triplett. He is a group sales consultant at Anthem Blue Cross and Blue Shield of Georgia. He serves Georgia based businesses and their advisors, helping them really understand their healthcare priorities and making recommendations for solutions within their insurance offerings. So, Mike, thank you so much for joining us tonight. We're really excited that you're going to kind of take us on this journey to understand how to choose health insurance.
No, thank you, Dr. Mel. Great to be here. I appreciate you guys having me on the show.
Absolutely. Well, we're going to be basic to start off with, like health insurance 101. We're just going to throw out there some terms so that everybody knows what they are and we're all on the same page. So let's start off with premiums. We hear about you got to pay your premium. What does that mean?
So your monthly premium is the amount that you, the individual, the policy holder, pay towards your insurance. So think of that as a monthly fee, a monthly bill, almost like you do your cable bill, your internet, your phone bill. Every month, you're paying a certain dollar amount that goes towards uh, paying for that insurance plan. And depending on where you're insured, whether that be individual or employer sponsored, either your employer or at times the federal government subsidizes some of that premium, so you're not exposed to the entire premium of the plan. So that's what you're paying and contributing on a
Mhm.
monthly basis to offer that.
Okay. All right. Well, then in that case, if that's the premium, your monthly payment to have the insurance, what is a deductible?
Yeah, so the deductible is a component of the health plan of the insurance benefit. So typically when we review our benefits, one of the first things we familiarize ourselves with is the deductible. The deductible is the amount of health services that you have to pay before the healthcare company begins reimbursing and paying in your place. So, for example, if you have a $2,000 deductible, and incur a $3,000 claim, you, the member, will pay the first $2,000, and then after which insurance kicks in, whether that be at 100%, whether that be at a smaller percentage, or possibly at a copay. But the deductible is the amount you've got to pay upfront before the health insurer starts reimbursing services.
Got it. Got it. All right. So I think pretty much people probably know what premium and deductible are. Let's move on to co-insurance. What is co-insurance?
Right, right. So co-insurance is a cost share that the member pays once they've met their deductible. Typically, it's in increments of 10%. Plan can pay 100%. You, as the member, could pay 100%. The plan could pay 50%. So, depending on the plan you're in and the plan design, you could be liable for a certain percentage of charges. And so, in that same $3,000 claim example where you've satisfied the first $2,000 and the remaining amount is $1,000, If you're paying 20% coinsurance, you're responsible for the next $200. So coinsurance kicks in after the deductible, and it's another way that members, the policyholder, shares in the cost of their services.
So conceivably, then you could just, I mean, if you have a lot of medical bills and you're paying 10%, um, even after satisfying your deductible, or 20% coinsurance after you satisfy your deductible, you could be paying thousands and thousands and thousands of dollars. Is there any cap to that?
There is, Dr. Mel. That's referred to as your out-of-pocket maximum. And the federal government on an annual basis sets limits for how high that out-of-pocket maximum can be within health plans. But your out-of-pocket maximum is the cap of what you can contribute towards your health insurance claims for the year. So you've satisfied your deductible, you're incurring additional co-pays or co-insurance throughout the plan year. Once you've hit that out-of-pocket maximum, you pay nothing else. The plan pays for your services at 100%.
100%.
So
Okay.
the out-of-pocket maximum really establishes how much all in you're in for covering your claims for the year.
So that's a pretty important number to know, especially if you're somebody that you or somebody who's on your policy is going to the doctor a lot, or has some health condition that requires a lot of services.
Right,
So
right. And
yeah.
oh, go ahead, Dr. Mel. I
No,
apologize.
you go ahead.
No, it's an important piece of your plan to be aware of deductible out of pocket and what are the mechanics of that plan, right? Some plans have lower exposure to the deductible. Some plans are richer in copays where you're paying a simple payment to see a doctor. There is no deductible, no coinsurance. So dependent on the plan design you enroll in can really impact how much of that deductible or out of pocket you're asked to satisfy through the year based on your health condition.
Right, right. Now, those are sort of the basic terms in terms of knowing what your costs are going to be. Now, what about your ability to determine what doctors you go to? So, I'm going to ask you basically to help us understand what's the difference between a HMO, and what is a HMO, and how does that different from a PPO or a POS plan? We see these initials, these acronyms thrown around. What does that mean in terms of who I can see and how I access healthcare?
Yeah, of course. That's a great question because not all plans are created equally in this sense. So at a high level, HMO, POS, PPO, these are all networks. And when you're talking about networks, a network is a group of doctors, healthcare providers, and hospitals that contract with the insurer to establish reimbursement for services for its patients. So commonly you'll hear members saying, or patients or people out on the street saying, hey, I need to see an in-network doctor. Is this doctor in my network? It speaks to these networks we're about to talk about here, and really what the implications for you as a patient are. Typically, a doctor that's in your network, you're going to be responsible for less in cost than a doctor outside your network. But to kind of backtrack and go through the options, an HMO is known as a health maintenance organization. And so this is a network setup that's been around for years, even pre-ACA. And really, there are three unique characteristics that
No, I'm
distinguish
sorry. I'm going to
an
stop you
HMO.
for. I'm going to stop you for pre-ACA means pre-2010, when the Affordable Care Act, also known as Obamacare, was passed. So, right.
That's correct. That's correct.
Okay.
And thank you for that note there, Dr. Mel. So HMOs have been around a long time, and again, that's health maintenance organization. And so really the three distinct characteristics that make an HMO stand out versus a POS or a PPO. So one, you've got access to in-network care only. There's not an out-of-network option in an HMO plan. The second piece is that you're required to select a primary care physician. And so your primary care physician plays a critical role, an important role in that HMO arrangement. really quarterbacking and navigating your care, whether that be there in their primary care office, or if you need more advanced services, if you need to see a specialist, providing that referral. So in network only, PCP selection. And the third piece is kind of what I alluded to there, is that you need a referral from your primary care physician to go see a specialist. So if you're somebody that sees a cardiologist, a dermatologist, an endocrinologist, typically you have to go see your primary care physician and have them write you a referral if you need that next level of care. So HMOs are a very popular option. It's what you see commonly in the individual marketplace plans. Going now to the other end of the spectrum, you've got your PPO, your preferred provider organization. Distinctly, this is different than an HMO in the sense that a PPO has both in-network and out-of-network coverage. So you've got doctors that fall in your network, but if you accidentally, in an emergency or by choice, go to an out-of-network provider, you've still got coverage. While it's more limited than in-network, you've still got coverage and protection from the insurance company.
Right.
And a PPO is really going to offer you the broadest choice of doctors, both in network and out of network. Typically, the PPO is much larger and has a broader choice than what an HMO happens to have. And then third, a point of service plan that really falls somewhere in the middle of the spectrum between a PPO and an HMO. Similar to a PPO, and POS stands for point of service. Excuse me if I didn't say that, but point of service, like a PPO plan, has both in-network and out-of-network benefits. So you've got that choice of network provider, but also it may require PCP selection. It may require that a PCP provide a referral for you to go see a specialist. I've seen these plans administered in different variations. They do require a primary care selection. They don't. But essentially, POS falls in the middle between a PPO and an HMO. Typically, the size of the network is comparable to a PPO, not as narrow a selection as what an HMO may be. But you're typically able to see cost savings on a point of service network. Maybe the doctors, the hospitals have a different contract, a different reimbursement rate for that POS network compared to the PPO. And so from a premium perspective, what you're paying as an individual or what your employer is paying towards the insurance may be lower on a POS plan as opposed to a PPO. So those are really your three options.
Yeah, no, thank you. That was a great walk through that. And one thing I just wanted to highlight is that a lot of times at HMO, the premiums are lower because the idea is that having to get a referral from a primary care physician, that primary care physician may be able to take care of the issue themselves and not refer you on to a more expensive specialist. So there's sort of like a gatekeeper function there with that primary care physician. So you end up not having to go to the more expensive doctor. So overall, the insurance company doesn't have to sort of pay as much for your care, so your premium is lower as compared to a POS or a PPO plan, where you have more freedom because you can choose the doctors that you want to, but you might sometimes end up, say, going to see a dermatologist for something that your primary care could have taken care of. So that's kind of the philosophy. And I hear a lot of people sometimes upset because they choose the plan that's the cheapest, the HMO, and then they're upset because, for example, they might have a primary care doctor who they love, but's not in that HMO. And so they're kind of, out of luck because they can no longer go to that doctor because it's not covered under that plan. So if your doctor isn't covered under the plan, do health insurances ever add doctors at the person's request?
So we do, insurance companies do. And so how that process works, typically, during in instances where you change health insurance carriers, or maybe you're on an insurance plan and your doctor goes out of network, a lot of insurance companies have established a transition of care policy, or a continuity of care policy, not to be confused with COBRA, but continuity of care, providing care to members at their current doctor, even if that doctor is at a network. And so for certain conditions, whether you're managing a chronic condition, whether you're pregnant, whether you have some sort of other complex ongoing condition, you may be able to keep your doctor when you change health plans, or when doctor goes out of network. And in that arrangement, essentially what you're doing is asking the insurance company to work directly hand in hand with your provider to arrive at what's called a single case agreement, which is essentially a agreement between the insurance company and your doctor that says, Mr. Doctor, we know you're not currently in our network, but for this patient, for Dr. Melissa Clark, we'd like you to accept an in-network reimbursement from the insurance company. And so there are opportunities when members' doctors aren't in network to either continue that coverage through that doctor for a predetermined period of time, or even make that suggestion to your health plan. Your health plan has a network contracting team who's working on building that network throughout the year. And so if they understand that their patients, their members value the services provided by a doctor, they may be more inclined to engage and contract with that doctor. So those opportunities do exist.
Great. So you've alluded to it already, but now I'm sitting down in front of the computer and I have to make a choice, right, of these plans. What are some of the things that I should have in mind about my own situation that's going to help guide which plan I choose?
Right. So I think the first part, in using your term, making wise health decisions from a member's perspective, really has to do with first understanding the choices that are out there. So there's really 5 buckets that most people fall into at open enrollment, where they place their insurance. So you've got employer sponsored, that's the insurance that you're offered to at your place of work. That includes your COBRA, which provides coverage when you lose a job, when you change professions, your extended coverage for a period of time. So you've got employer-sponsored coverage. Second, you've got Medicare, which is a pool for people that are over age 65. Medicare Traditional and Medicare Advantage, which is a newer form of Medicare, but it's provided by private insurance companies. Third, you've got Medicaid and Children's Health Insurance Program, which is a joint federal and state program that allows people on a limited income with a financial need to secure coverage at little to no cost, whereas they otherwise would not have been able to afford insurance on the exchange or through their employer. Fourth are the exchanges. So both, whether that be at the federal level, healthcare.gov, or a state-based exchange like California, Covered California, for example. Those are your individual exchanges where you can buy ACA compliant plans. And then fifth, you've got your private market options. Those are your short-term medical plans, indemnity, catastrophic sort of plans, intermittent plans. So really first understanding what are your options and where are you at in your life that may trigger either an employer-sponsored plan, may send you to the individual market. So understanding the choices, but I think some of the important.
And let me just jump in there. So we actually did a segment on previously on Medicare and Medicaid separately. So now we're kind of narrowed down to whether you're getting it from your employer, whether you're buying it on the marketplace, or whether you're buying an off marketplace plan, which I wouldn't really advise for anybody to do, because they don't have the protections, the federal protections, like making sure that, mental health is covered, for example. They don't necessarily have all the safeguards that plans that you would get on the marketplace have to protect the consumer. So really, we want to kind of just narrow it down to 2 then: employer sponsored or buying on the marketplace.
Right, right. And so, you can look at it from the lens of an individual buying on the individual market, an individual that is employed through an employer who offers health benefits. So I think when you're going to the individual market, first you want to understand, especially with the exchanges, do you qualify for any subsidies? So
Mhm.
people can qualify for federal subsidies. It's typically based on your household income. But you could be subject to less premium than you would pay without that subsidy. And so that's called the advanced premium tax credit that members can take advantage of, people on the exchanges can. And so when you go out to healthcare.gov or when you go to your state-based exchange, it'll ask you for an estimate of your income and it'll tell you what you qualify for in terms of a tax credit. So I think as an individual, you first want to understand whether you have employer coverage or not. On the individual market, what does that subsidy level look like for you, and how much can you have the government contribute toward that monthly premium that you're paying for the coverage? I think second on the individual market is looking at insurance company availability. So that changes tremendously year in and year out. Just as an example, for where I am here in Atlanta, Georgia, in Georgia, we had 12 insurance companies last year participating in the insurance exchanges. This year, we just have 9. So a
Wow.
loss of almost 25% of participants in the Georgia market. You've
Mhm.
seen the exit from some insurance companies that entered during COVID. So that availability of plan offerings changes significantly throughout the year. And so just because an insurance plan is offered on the exchange in your county this year in 2023 doesn't necessarily mean it'll be offered by the same insurance company in your county for 2024.
So you
And so I
kinda you
think
gotta
just
have to reevaluate every year and make the choices based upon what's offered.
right, exactly. And
Mhm.
and your exchanges can help you do that. They'll allow you to filter by the insurance companies that are offering plan designs. So I think availability is important. And then kind of hitting back on the network piece we talked about, not all networks are created equally. You've got to be sure before you enroll in a plan to look at the provider directory and be sure that the doctors you use today are in network.
Mhm.
And if not, if you don't have an established care team, you may be new to an area and don't have doctors you routinely see. Make sure that doctors and hospitals and healthcare providers, urgent care centers that are near you, near where you live, are in network. You really have to put your hat on and think, while you may be healthy today, while you may be in a good state of wellness today, something could happen down the line. And I think you really need to consider where you are going to go when those things
Mhm.
happen. So just making sure that the network is suitable to you. Um, and then plan design is important. We talked about deductible, coinsurance, out of pocket maximums. Those things have a serious implication on what you will pay out of
Mhm.
your pocket. And so,
Right.
when you're possibly younger and healthier, you feel like you need less of a rich insurance plan. And so you're more willing to pay a lower premium, but that comes at a risk of having higher out of pocket exposure if you ever do have a health
Mhm.
condition, an accident. And so kind of thinking about some of those mechanics like deductibles, coinsurance, out of pockets, but also some of the options that are out there from a plan design perspective.
Right.
We've heard a lot over the years about high deductible health plans and HSAs.
Well, before
Um,
before we get to that, before we get to that, um, I wanted to go back to something that you had asked, that you had mentioned before about, the discounts that you might be eligible for on the marketplace. How do they, for people who are individuals, self-employed entrepreneurs, how do they verify your income to know that you're eligible for those discounts?
Right. So, healthcare.gov being a federal exchange, and they rely heavily on trusted sources like the IRS, Social
Okay.
Security, third party credit services like Equifax to verify your income.
Mhm.
Now, a component to consider, not everybody has predictable income. And so, what the
Right.
marketplace allows you to do throughout the year is you can always attest to what your income is. If that changes throughout the year, if you get a better estimate throughout the year. And the reason that's important is because that impacts the advanced premium tax credit that you qualify for. And, you know, if you overestimate your income, you may not, may not receive as rich of a subsidy. If you underestimate your income, you may owe money at the end of the year.
Right.
So
So it's
it's important
important to be right in the middle, right there on the sweet spot. So,
right.
I know we're about to go to audience questions. I want to get into what you were about to say. What are high deductible health plans, and how are they supposed to work to incentivize people to stay healthy?
Right. So high deductible health plans really were all the craze sort of in the 2000 teens, 2012 to 2016, as the ACA, the Affordable Care Act, was rolled out. Healthier people that didn't need as rich benefits, were looking for a way to have coverage to avoid ACA penalties, but to also pay a lower dollar premium. And so an HSA, essentially from a plan design perspective, a high deductible health plan has a high deductible, typically $3,000 or more. Many times we see at 5,000, 6,000. It's got a high deductible. And that's paired with what's known as a health savings account. A health savings account is an account where you can save pre-tax dollars from your income that go toward future medical expenses. And so it's a way to have a tax advantaged healthcare account for you down the line when you need it. And you can use that HSA to pay for healthcare services. So when you've got to pay a deductible, a coinsurance, you've got to reach your out-of-pocket maximum, that's supposed to provide some protection. And in many instances, especially on employer-sponsored plans, your employer may contribute to that HSA, may match you. And then you've got some flexibility within that HSA account, similar to a retirement account, a 401k. Many times you can invest those funds and let them grow over time. And so if you're somebody that's healthy today and want to save for those healthcare expenses in the future, an HSA account is a great way to do that. So it's a popular option, but they really came to be post Affordable Care Act.
Right. Wow. Well, it is time to take audience questions, and I'm sure there's some out there. So, Wayne, I don't know what you're seeing in the chat, but if you can come on back on and let us know if there are any questions for Mike.
There is not one question for Mike. No, I'm just kidding. Mike, there are a great many questions for Mike. And I want to start with Sophia in Los Angeles. And Sophia has a question about what alternatives to Delta Dental exist in your health plan.
Yeah, so Delta Dental is a dental insurance company. And so there's a number of dental insurance companies: Delta, MetLife, Principal. You've got a number of specialty insurance companies, but also your traditional major medical insurance companies like Anthem, like Cigna, like United, like Aetna also offer dental benefits. And so, yes, there is choice when it comes to dental benefits, whether that's covered under your medical plan or offered as a separate standalone policy. There are certainly other options than Delta Dental. That's an open market, just as the medical insurance is. And there's probably more insurance companies that participate in those specialty lines of coverage than medical. So a ton of choice out there.
But important to note that medical insurance does not necessarily cover dental, especially preventive dental care, cosmetic dental care, none of that. Only if, like, say you have a dental emergency, like you develop an infection as a result of tooth decay, then they might cover something like that, but certainly nothing preventive. You need separate dental insurance for that.
Okay. Lisa would like to know, how do I know if a certain procedure, surgery, or service is covered by my health plan?
Great question. And that's something people contemplate before enrolling in the health plan. So you think about how you do that in advance. Once you've enrolled in a plan, I think it's really simple to confirm a procedure is covered either by calling the member services number on the back of your ID card and speaking with member services. But also, your doctor that you see has the ability to verify your benefits. And so if you're in a doctor's visit and they recommend a course of treatment, they can also confirm on their side whether that benefit is covered. And then you'll see a lot of insurance companies today have a procedure shopper tool they make available through their website or through their phone apps where, you can go in there, either enter the name of the procedure. You can be more specific and enter a CPT code, which is a code used by providers to really explain what a service or a claim is for. But most insurance companies offer those services now, so you can have some sort of transparency and predictability before seeking services.
Okay.
Good to know.
We have most people complain. We have a lot of complaints in the chat about people complaining about their health insurance companies denying their claims all the time. So we have this question from Marquise and then a follow-up question. Marquise wants to know what causes most claims to be rejected.
Gosh, that's a great question as well. So you've got a myriad of reasons a claim could be denied or rejected, or even pended, not denied or approved, but pended for additional information. One is the benefit could be a non-covered service. So if the benefit is not included in your summary of benefits coverage, it may not be covered by the insurance plan. That could create an instance where your claim is being rejected. Additionally, there are certain services like inpatient hospitalizations, transplants, certain outpatient procedures that require pre-approval by your insurance company. That's something that your doctor submits in advance. But if that step hasn't been completed and you haven't gotten that pre-approval, that could be another reason a claim is rejected.
Is that what they call the pre-auth? I hear that term every time I go into a doctor. Is that the pre-auth?
That is pre-authorization, pre-certification, prior approval, all similarly coined terms, but mean the same thing. Yes.
But I can say sort of in general as a rule of thumb, if something is not medically necessary, meaning like it's a cosmetic procedure, so a facelift or a tummy tuck, you can pretty much assure that that's not going to be covered. Or if something is considered experimental, meaning, there's not enough medical evidence to show that it's really going to give you the outcome that you seek, though that's definitely not going to be covered. With rare exception, that's not going to be covered. And then everything else that Mike mentioned that requires pre-authorization, sometimes it gets pended, like he said, because your doctor didn't offer enough information, give enough, answer all the questions that need to be answered so that the insurance company can approve it. So a lot of times
it's a doctor's fault.
Well, not necessarily their fault. They might not have realized. And so sometimes it's just a matter of your doctor calling the insurance company and talking to the insurance company doctor and getting it all ironed out over the phone. And then most of the time it goes through after that.
Okay. What recourse do you have when it happens? That's the second part of this question.
Yeah, so the easy answer is you have the right to appeal. If you feel a claim has been incorrectly rejected or pended, you've got the ability to appeal that claim. And so what will happen is you initiate that appeal. Typically that's reviewed within 30 days by the insurance company, and they come back with the decision that either, renders a different verdict for the claim, maybe a positive verdict where the claim is now covered. There could be an additional request for information, a peer-to-peer review like Dr. MEL alluded to, where your physician may be speaking to a board certified physician at the insurance company to make sure that your care is medically necessary and applicable. There are opportunities to appeal rejected and denied claims. And then I also think there's an opportunity to get out ahead of it, sort of what we said around procedure shopping,
Mhm.
speaking to the insurance company, prior approval. Some of those steps in advance of services can ultimately help you avoid a denied claim. But the easy answer is you've got the right to appeal any rejected claim.
So I was in. So this is personal. I was in the doctor's office recently, and I overheard. I wasn't supposed to hear it. I guess the HIPAA. It might have been a HIPAA violation, but someone, girl, girl was talking. The woman from the doctor's office was talking to someone, and she said, "Your, I think it was Ozempic or Monjero or one of those drugs, was denied by the insurance company." And I think people are using those drugs now for weight loss, which is a benefit to their health. Why would the insurance company turn something like that down? I mean,
Yeah, that's a great question, Wayne, and that's really been a fluid subject in health insurance this year. I think a lot of insurance companies have seen the emergence of those GLP-1 drugs. That's the class of drugs that those Ozempic fall into. Those GLP-1 drugs being used for weight loss. Those drugs are created and used for type 2 diabetes, diabetics. That's what they were created for. And so there's concern by insurance companies that maybe use for weight loss isn't ethical. Maybe it's not. Maybe it hasn't been proven through evidence-based medicine. And so, there's sort of been some concern on the insurance side that it exposes the health plan to more cost, whether that be your employer, if they're a self-funded employer, whether that impact your premiums on a year over year basis. So I think the position a lot of insurance companies have taken as of this year is to require pre-authorization for those drugs, like we alluded to. But typically, they want to cover them when they're indicated for diabetes rather than weight loss, because there are other equivalents, there are other drugs on the market that may be more suitable for weight loss. But I think it's an area that the insurers, providers, patients are learning more about, and I think you'll continue to see that being fluid. So if that claim is rejected today, I don't know that's the case a year from now, 6 months from now. I think insurance companies are pretty fluid in that coverage.
okay.
And full disclosure, I at one point in my life worked for an insurance company as a physician, and after I left that employment was when I wrote "Excuse Me, Doctor," and the whole last chapter of the book is helping consumers understand how to deal with those issues of interacting, not just choosing insurance, which it covers, but also interacting with your health insurance plan when there are issues that come up around that. So if you're interested in more about that, you can also check out "Excuse Me, Doctor," the book, because it'll give you the insider's guide,
Is
so to
that
speak.
that a plug, Dr. Mel? Is that a
That is a
plug
plug.
for?
It's a plug, but it's also a recognition of the time that we're running out of time, and
We're
people
running
might
out of
still
time.
have questions and want to pursue that, and that's a resource that
And
they
you
can use.
absolutely have the final word on that. We are out of time.
Oh my goodness. Wow. Well, I really appreciate Mike your stopping by and joining us to walk us through how to choose insurance, what the considerations are that we need to have as consumers when we look at our employers' offerings, or if we're looking at the marketplace offerings, whatever we're doing it, what we should have in mind. So thank you so much for walking us through that. We really appreciate you.
Yeah, I appreciate it. Thank you guys for having me. It's a timely discussion we're having today as open enrollment kicks off, and it's really the one time a year most Americans have the ability to exercise their choice in healthcare. So we want to make sure folks are as informed, making wise decisions as possible.
Great. Thank you so much. And thank you, Wayne Bruce, for bringing those questions from the audience. Fantastic. And of course, thank you to the audience for my Be Health Empowered family for those excellent questions. And also remember, too, before I sign off, that you can still enroll in that Howard University study that I've mentioned before, the COVID Resilience Research Study. All you have to do is fill out 2 surveys. It's entirely voluntary. You could be compensated up to $100. It's holiday time. You might want to spend that in some kind of way coming up. So this is an opportunity still to enroll. If you're interested in checking it out, remember it's entirely voluntary. Reach out to Dana Harvey at danaharveyresearch.com. Dana Harvey Research at gmail.com. Sorry. So that's Dana, D-A-N-A, Harvey, H-A-R-V-E-Y, research at gmail.com. That is it for us, y'all. Thank you for tuning in. We really appreciate you. And remember, until I see you next time, be wise, be well, and be health empowered. Thanks so much for tuning in.
This one here is vaxxed and boosted. My little brother has asthma, which means he's 6 times more likely than a healthy kid to go to the hospital.
Uno out.
You cheated. I'm not doing the dishes.
If I play my cards right, I am so glad they let me in.